Hi friends, welcome. Today we are going to discuss about thyroid lesions. Okay, all the thyroid related to surgeon's point of view. Okay, I'm going to relate thyroid related to surgeon's view. So before going into thyroid, let me discuss the basics of thyroid. You should know about the introduction like anatomy, physiology, and about the various nerves and about the various other issues. You should have an idea here. Let me start with anatomy of thyroid gland. Anatomy of thyroid gland. Anatomy of thyroid gland I'm going to discuss now. So please remember, I'm going to draw a very important picture now. So thyroid gland is a butterfly shaped gland. It is derived from, please understand, it is derived from thyroglossal tract like this. Thyroglossal tract comes and divides into two like this. Thyroglossal tract comes down and divides into thyroid bud and forms the thyroid gland. And this is starting from foramen cecum. This is from foramen cecum. You start this. Okay, we get this from foramen cecum. Please don't forget this. It starts from foramen cecum. It descends down and divides into two. So now, at this point, I want you to know there are certain bodies known as ultimobranchial bodies. Ultimobranchial bodies. From this ultimobranchial bodies, we get another cell known as parafollicular C cell. I want you to remember the cells are known as parafollicular C cells. I want you to know about the cells known as parafollicular C cells are derived from ultimobranchial body. So please remember this anatomy. Now, I'm going to tell you the blood supply of thyroid gland. Blood supply of thyroid gland. This is superior thyroid artery which enters the thyroid gland and divides into branches. This is from external carotid artery. So superior thyroid artery is coming from external carotid artery. It enters the thyroid gland and then divides into branches. And this is inferior thyroid vessels. Inferior thyroid vessels. You can see the inferior thyroid artery is divided before entering the gland like this. Before entering the gland itself, it is divided like this. So this is inferior thyroid artery which is usually coming from thyrocervical trunk. So please don't forget it comes from thyrocervical trunk. So it comes from thyrocervical trunk of subclavian artery. It is a branch from thyrocervical trunk of subclavian artery. So it comes inside and divides into multiple branches. And one important branch from inferior thyroid artery supplies the parathyroid glands. One important branch from inferior thyroid artery divides and supplies the parathyroid gland like this. So therefore, now one concept you have to understand here. When we are doing surgery, superior thyroid artery was ligated close to the gland like this. And old concept was inferior thyroid vessels are ligated away from the gland like this. This is the old concept. Why this type of ligation is to prevent injury to the nerve here. The nerve here known as external laryngeal nerve. To prevent injury to the external laryngeal nerve superiorly and to prevent injury to the recurrent laryngeal nerve inferiorly. This was done before. So to prevent nerve injuries, we ligated the superior thyroid artery close to the gland, inferior thyroid artery away from the gland in olden days. But what happened as we start ligating the inferior vessels away from the gland? What happened? What problem happened in this? As you start ligating it away, the major issue which happened is it will result in loss of blood supply to the parathyroid glands. It resulted in loss of blood supply to the parathyroid glands. So therefore, the patient resulted in hypocalcemia. So therefore, now what we do is now we ligate it close to the gland like this. Now we ligate it close to the gland. So both superior thyroid artery as well as inferior thyroid artery both are ligated close to the gland. Please don't forget they both are ligated close to the gland. Both superior thyroid artery as well as inferior thyroid artery are ligated close to the gland. Is there any other artery supplying the thyroid gland? Yes, from the arch of aorta we have one another artery supplying the thyroid known as arteria thyroidea ema. This is known as arteria thyroidea ema. It is seen in 3% cases. In 3% cases, there is one artery directly coming from the arch of aorta and supplying the level of isthmus. This is known as arteria thyroidea ema. So please don't forget the embryology of thyroid gland is it is derived from the thyroglossal tract which comes and divides into two lobes and forms two glands, right and left gland. By chance, if it is not descending down, it is remaining there itself. That is like most common site of ectopic thyroid. That is known as most common site of ectopic thyroid. Please don't forget that is known as most common site of ectopic thyroid. It is also known as lingual thyroid. It is also known as ectopic thyroid or lingual thyroid is the most common site. So please don't forget this point also. Okay. So now let me discuss about the venous drainage. So I discussed about arterial drainage. Now I am going to discuss about the venous drainage. Superior thyroid vein, same way it is formed as a single vessel. It goes and drains into internal jugular vein. It drains into internal jugular vein. Inferior thyroid veins will form multiple tributaries and drain into brachiocephalic vein. That is middle thyroid vein which drains into internal jugular vein. Please remember one MCQ point here. In the artery there is no middle thyroid artery, but there is internal jugular vein present. In artery there is internal jugular vein present, but there is no middle thyroid artery. So there is middle thyroid vein present, no middle thyroid artery, and there is one fourth vein known as Cocker's vein, which can drain into internal jugular vein or into brachiocephalic vein. It can drain into any of this. It can either drain into internal jugular vein or it can drain into brachiocephalic vein. So the venous drainage is very clear cut. There are four veins. Superior thyroid vein drains into internal jugular vein, middle thyroid vein drains into internal jugular vein, Cocker's vein drain either into internal jugular or brachiocephalic, and inferior thyroid vessels will drain into brachiocephalic vein. These are the branches of veins. Please don't forget this point. Okay, these are the various tributaries in the veins. So I hope you understood the artery and vein. Okay, artery and vein you should not forget. So now I'm going to discuss very important concept in this about the nerves. I'm going to now discuss about the nerves. So this is vocal cords. Okay, this is vocal cord. Let us assume this is a vocal cord. Now I'm going to discuss about the nerves coming towards the thyroid gland. For example, if this is a thyroid gland, I'm drawing approximately, this is a thyroid gland. Now we have the following nerves. So this is superior laryngeal nerve. Please remember this is superior laryngeal nerve which divides into two branches. One is supplying the vocal cord motor supply, pure motor supply known as external laryngeal nerve. Another nerve is internal laryngeal nerve which is pure sensory nerve. Please remember superior laryngeal nerve gives two branches, the external laryngeal nerve and internal laryngeal nerve. The external laryngeal nerve is pure motor nerve, internal laryngeal nerve is pure sensory nerve. So internal laryngeal is sensory to mucosa above vocal cords. So please remember the anatomy points. Internal laryngeal nerve is sensory to the mucosa of the larynx above vocal cords. External laryngeal nerve is a motor to only one muscle, that is cricothyroid muscle. What is this muscle? It is a tensor of vocal cord. Please remember it is a tensor of vocal cord. It is known as tensor of vocal cord. Okay, it is known as tensor of vocal cord. So and you have vagus nerve on both sides. From the vagus nerve you can see the recurrent laryngeal nerve. Why it is known as recurrent? Because from vagus it goes down and then comes up like this. From vagus nerve it goes down and comes up like this. After hooking at the ligamentum arteriosum, it will hook out at the ligamentum arteriosum. On the left side and at the arch of aorta on the right side. Since they hook out and come up, they are known as recurrent laryngeal nerve. There are two recurrent laryngeal nerve. So one is right side, one is left side. So this is recurrent laryngeal nerve. Please remember, if it is not hooking around this ligamentum arteriosum and arch of aorta, and they come directly. It is known as non-recurrent laryngeal now. Anyhow, the name is recurrent laryngeal now. Why it is recurrent? Because it goes down and comes up. So if it is not going down and coming up, it is known as non-recurrent laryngeal now. It is seen in around less than 5% cases. In less than 5% cases, we have non-recurrent laryngeal now. Okay, less than 5% of them will have this. So now this is recurrent laryngeal now, which has both motor as well as sensory. Please remember, recurrent laryngeal now has both motor and sensory supply. So what is the motor supply? It supplies all the muscles of vocal cord, including one important muscle known as posterior cricoarytenoid muscle. One of the important muscles, this is posterior cricoarytenoid muscle. It will make the vocal cord open like this. So posterior cricoarytenoid will open. So this is posterior cricoarytenoid muscle, which will open. Okay, it will open. Posterior cricoarytenoid is for abduction of vocal cord. So it is known as safety muscle of larynx. Safety muscle of larynx. All muscles are supplied, including posterior cricoarytenoid, and it is also sensory below mucosa of vocal cords. Below mucosa of vocal cords, this is sensory supply. So recurrent laryngeal nerve has both motor and sensory. Now you will understand what will happen if each nerve is damaged. If I am injuring the internal laryngeal nerve, what will happen to the patient? Can you tell me? If internal laryngeal nerve is cut during surgery, what complication will happen? There will be paroxysmal nocturnal cough. Please don't forget, there will be paroxysmal nocturnal cough, or there will be aspiration, otherwise known as aspiration. Because of loss of sensation in this area, the patient will have paroxysmal nocturnal cough or aspiration if internal laryngeal nerve is damaged. If external laryngeal nerve is damaged, what will be the complication? What symptom the patient will come to you? When the patient tries to shout, his voice will become husky. There will be huskiness of voice. Present. Please don't forget, there will be huskiness of voice. If external laryngeal nerve is injured, there will be huskiness of voice, also known as loss of timbre of voice. It is also known as loss of timbre of voice. You cannot shout with high pitch. The pitch becomes low. Loss of timbre means the pitch falls down. That is known as huskiness of voice or loss of pitch. So please don't forget internal laryngeal nerve injury. What will happen? External laryngeal nerve injury. What will happen? If recurrent laryngeal nerve, one nerve is injured, what will happen? Unilateral injury will cause hoarseness of voice. If bilaterally recurrent laryngeal nerve injured, what will happen? There will be stridor. Please don't forget, there will be stridor. If unilateral recurrent laryngeal nerve is injured, it is hoarseness. Bilateral recurrent laryngeal nerve injury is a separate topic in ENT that will result in stridor. Please don't forget, that will result in stridor. So now I hope you understood the nerve injuries. And what is the most common nerve injured in this list? Can you tell me what is the most common nerve injured in thyroid operation? What is the most common nerve injured? The most common nerve injured is, please don't forget, it is external laryngeal nerve is the most common nerve injured in thyroid operations. And because of external laryngeal nerve, there will be loss of pitch of voice or loss of timbre of voice or huskiness of voicing. Please don't forget this point. So external laryngeal nerve is injured most commonly in thyroid surgeries, not recurrent laryngeal nerve. Many students are thinking it is recurrent laryngeal nerve. No, it is external laryngeal nerve which is injured. That is the reason SWATS gives a classification of external laryngeal nerve course. So please remember, this is the course of external laryngeal nerve. It is seen usually running at the upper border of superior pole. At upper border of superior pole, external laryngeal nerve will be running like this. This course is given a classification known as Cernia classification. Cernia classification is the classification of external laryngeal nerve course in relation to superior pole. External laryngeal nerve course in relation to superior pole is known as Cernia classification. In type 1A, it is seen more than 1 centimeter from the superior pole. Type 1, it is more than 1 centimeter from the superior pole. Type 2, it is less than 1 centimeter from the superior pole. So in 2A, it is running above the gland. Anyhow, it is running above the gland. In 2B, it is running on the gland. So which is at high risk of damage. When you ligate it close to the gland also, which type is very high risk for damage? It is type 2B, in which the nerve is running on the gland. I will show you this image. Cernia classification. Please don't forget, Cernia classification is a classification of external laryngeal nerve course. ELN course. Okay, please don't forget, external laryngeal nerve course is known as, is given by this term, Cernia classification. Type 1 is above 1 centimeter. Type 2 is within 1 centimeter of the superior pole. In type 2, we have 2A above the gland and 2B on the gland, running on the gland itself. This is Cernia classification. And all of you know very well, the most important discussion in thyroid gland is only on recurrent laryngeal nerve. So let me discuss in depth about recurrent laryngeal nerve now. So recurrent laryngeal nerve. So see, I have not yet started the thyroid surgery proper. I am discussing only the basics of anatomy and about the nerves, artery vessel, etc. So now you see, the recurrent laryngeal nerve, I told you it is coming from vagus nerve. It recurs and comes up like this. As it is coming up like this, it is usually running in the tracheoesophageal groove. Please remember, it runs in the tracheoesophageal groove. For example, this is a trachea. It's a trachea, and it is running in the tracheoesophageal groove like this. And what is the most common site of injury of recurrent laryngeal nerve? Most common site of injury, or where is the risk of recurrent laryngeal nerve injury is more common? Where is the risk of recurrent laryngeal nerve injury is more common is given by a term Beer's triangle. This is highly expected MCQ for you from Bayesian law. Beer's triangle. What is Beer's triangle? Beer's triangle is bounded by, this is common carotid artery. Please remember, it is bounded by common carotid artery. It is bounded by tracheoesophageal groove. It is bounded by tracheoesophageal groove, and it is bounded by inferior thyroid artery. So these together forms Beer's triangle. Inferior thyroid artery, common carotid artery, tracheoesophageal groove. In this triangle only, recurrent laryngeal nerve is at common site of risk. Common site of injury is in this triangle. Beer's triangle. This is from Bayesian law. Beer's triangle is the place where the recurrent laryngeal nerve can get injured. Please don't forget this. And posteromedially, when you do surgery, posteromedially there is a projection in the thyroid gland. What is it known as? There is a projection in the posterior part. That is known as tubercle of Zucker-Candle. This is nothing but pointing tip towards recurrent laryngeal nerve. It is known as pointing tip towards recurrent laryngeal nerve. So this is one place where we identify the recurrent laryngeal nerve during surgery. Pointing tip towards recurrent laryngeal nerve is also known as tubercle of Zucker-Candle. Is a pointing tip to recurrent laryngeal nerve. Please don't forget this point. It is a pointing tip towards recurrent laryngeal nerve is known as tubercle of Zucker-Candle. So regarding recurrent laryngeal nerve, you should know everything. If unilateral nerve injury, it results in hoarseness, and nothing to worry, the hoarseness recovers in 3 months. Many times the other cord will compensate and the hoarseness will recover in 3 months. If it is bilateral recurrent laryngeal nerve injury, the patient develops stridor at the end of operation. Immediately at the end of operation, patient develops stridor. He develops stridor. So what you should do immediately when a patient recurrent laryngeal nerve bilaterally injured is suspected in the moment you extubate, if the patient is developing stridor, what you should do first? What you should do? We will not directly go for a tracheostomy. Please remember, first we will do re-intubation. That is the correct answer. We should re-intubate. Okay, and wait for 24 to 48 hours. If it is a neuropraxia, and when you give steroids, if it is just only a traction related paresis, it will recover. If it is not recovering in 24 to 48 hours, then with the help of ENT surgeons on table, you extubate. And if the patient is developing stridor or both cords are going for cadaveric position, bilateral stridor is due to the cords going for cadaveric position. If bilateral cord is going for cadaveric position, at that time only you will plan a tracheostomy. We will plan a tracheostomy. And the patient will be on tracheostomy for few months. Afterwards, you have to examine whether the vocal cord is functioning, is coming back or not. If it is not coming, and if it is a permanent damage, of bilateral recurrent laryngeal nerve, what will you do? Permanent damage of bilateral recurrent laryngeal nerve, we have to advise them undergo arytenoidectomy, or lateralization of cord. These are all the procedures you will read in ENT. What will you do for vocal cord bilateral paralysis? Lateralization of cord, arytenoidectomy will be done. These are all nothing but these are all types of thyroplasty. You will be reading in ENT. These are all types of thyroplasty will be done for these cases. Though these are not related to me, so just I want to give a complete finish for stridor. Stridor, immediately intubate, wait for 24 to 48 hours, and extubate in presence of ENT surgeon. If it is again going for stridor, or if both vocal cords are gone, you must go for arytenoidectomy or lateralization of cord should be done. Please don't forget this. Arytenoidectomy or lateralization of cord should be done for such patients. So are you clear? These are the points I want you to remember from anatomy of thyroid gland. So these are the points from anatomy of thyroid gland. Anatomy of thyroid gland. What are the points I told you? There are. What do you mean by lingual thyroid? What do you mean by lingual thyroid? I want you to know the basic MCQs after an exam from surgery books. Lingual thyroid is the most common site of ectopic thyroid. It is the most common site of ectopic thyroid. It is nothing but undescended thyroid. Undescended thyroid and development of undescended thyroid bud with the development of thyroid gland in the foramen cecum itself. The patient will have clinical feature of deglutition problems. Difficulty in swallowing will be that. Patient will have a huge swelling in the foramen cecum level, and they will have deglutition problems. Deglutition problems are seen in these cases. Okay, so this is classical feature of lingual thyroid. Lingual thyroid is the most common site due to undescended thyroid bud from the foramen cecum down. Please don't forget this point. And please don't forget there are three arteries: superior thyroid artery and inferior thyroid artery and arteria thyroidea. The latest concept is superior thyroid artery and inferior thyroid artery should be ligated. Close to the gland is the latest concept. Close to gland we have to ligate. And when you come to veins, there are, apart from superior thyroid vein, middle thyroid vein, inferior thyroid vein, we also have Coccus vein is also present. There is also Coccus vein present. Okay, and don't forget about the nerves. The external laryngeal nerve is the most common nerve injury. Therefore, we have a classification known as Cernia classification of external laryngeal nerve injuries. And internal laryngeal nerve injury causes paroxysmal nocturnal cough. Recurrent laryngeal nerve injury is most common at Beer's triangle. Please don't forget it is most common at Beer's triangle. So it is at the level of tracheoesophageal groove, between the junction of tracheoesophageal groove, common carotid artery and inferior thyroid artery. That is known as Beer's triangle. So I want you to remember these anatomy points thorough for your exams. Are you clear? Now I am going next to physiology of thyroid gland. Please don't forget, next I am going to the physiology. I am going to draw a single picture. This single picture will make you understand the entire pathology in thyroid gland. Okay, so I am going to draw a single picture. So please understand this single picture. If you understand, you are completely clear in physiology. So I am eating a fish. So 0.1 to 0.15 to 0.15 milligram is an essential requirement of iodine, daily requirement of iodine. Iodine requirement per day is around 0.1 to 0.1 milligram is required per day. So the fish is consumed. Now. The fish is consumed. That is immediately trapping the iodine present in the fish. Iodine is trapped into the gland. So first step is trapping. As you eat a fish, iodine is trapped. Trapping of iodine is the first step. Then comes the iodine is oxidized to iodide. Please don't forget it is oxidized to iodide. That is the second step. Oxidized to iodide by a substance known as thyroid peroxidase enzyme. Known as thyroid peroxidase to iodide. Then the iodide. So second step is what? Trapping of iodine. Second step is oxidation of iodine to iodide by thyroid peroxidase. Then the third step is the iodide will bind with thyroglobulin, and cause monoiodoglobulin and diiodoglobulin into the gland. They will result in monoiodoglobulin and diiodoglobulin. So third step is binding with thyroglobulin. Oxidation by thyroid peroxidase, binding with thyroglobulin. Then this monoiodoglobulin and diiodoglobulin will go for coupling. These guys will go for coupling. So MIG with the DIG coupling will result in T3. DIG with the DIG coupling will result in T4. And that is the last step known as coupling. So the physiology of thyroid gland I can tell in 4 words known as TOBC. So please remember trapping, oxidation, binding, coupling. That's all. The entire physiology of thyroid gland is trapping of iodine, oxidation of iodine to iodide. Then iodide will be binding with thyroglobulin. Then thyroglobulin will couple. The thyroglobulin will result in monoiodine diiodoglobulin. That will result in coupling and results T3, T4. T3 has an half-life as only 1 day, 24 hours only. Whereas T4 has an half-life of 7 days. And peripherally T4 is converted to T3. Peripheral, that is T4 conversion to T3 because it is only T3 which is active. T3 is an active product. T4 is inactive product. So T3 is active. So peripherally T4 gets converted to T3. This entire physiology is stimulated by a receptor sitting on the gland. It is known as TSH receptor. This receptor is stimulated by TSH coming from pituitary. Once there is T3, T4 released, they will go and produce feedback inhibition for TSH. So please remember when T3, T4 is released into the circulation, they will produce TSH feedback inhibition. Sir, why are you discussing this much about physiology? Means because all my topics which I am going to tell now are based on this physiology only. So I want you to know the physiology. I am now going to discuss about the various surgical diseases. The most common cause of hypothyroidism in the world is due to iodine deficiency. Iodine deficient goiter. Iodine deficiency causing goiter is the most common cause of hypothyroidism all over the world level. Please remember, all over the world level, that is the most common cause. So one by one, each step I will tell you the problems. If there is a congenital thyroid peroxidase deficiency, what is that syndrome known as? If there is a congenital thyroid peroxidase deficiency, what is the name of that syndrome? High yield MCQ for PGME, what is it? What is the name of syndrome in which there is a congenital thyroid peroxidase deficiency is known as Pendred syndrome. So please don't forget it is known as Pendred syndrome. Congenital thyroid peroxidase deficiency is known as Penrod syndrome, characterized by sensory neural hearing loss plus congenital hypothyroidism. It is characterized by sensory neural hearing loss plus congenital hypothyroidism. That is known as Penrod syndrome. That is known as Penrod syndrome. So please don't forget, congenital thyroid peroxidase deficiency is known as Penrod syndrome, characterized by sensory neural hearing loss and congenital hypothyroidism. Okay. Then comes the next disease known as Hashimoto's thyroiditis. What happens in Hashimoto's thyroiditis? Please understand the physiology. This is the physiology we are discussing. In Hashimoto's thyroiditis, there is antibodies produced against thyroid peroxidase, against thyroglobulin, against TSH receptor. So antibodies are produced against all these substances like thyroid peroxidase, most commonly thyroglobulin, TSH receptor. It is antibody produced against these substances. So antibodies produced against thyroid peroxidase, thyroglobulin and TSH receptor. So this is known as Hashimoto's thyroiditis, and Hashimoto's thyroiditis is the most common cause of hypothyroidism in Western countries. Please remember, it is the most common cause of hypothyroidism in Western countries. See, I have told you about hypothyroidism now, many causes. Cause number one I told you is iodine deficiency goiter. Okay, cause number one, iodine deficiency goiter. Then I discussed about Penrod syndrome. Then I discussed about Hashimoto's thyroiditis. All these are various causes of hypothyroidism. So is there any cause of hyperthyroidism? Yes, there is one cause known as Graves' disease. What happens in Graves' disease? Please remember this picture. In Graves' disease, what happens is there is stimulatory antibodies produced. There will be stimulatory antibodies produced against thyroid peroxidase, TSH receptor and thyroglobulin. There will be stimulatory antibodies for TPO, TSH receptor and thyroglobulin. They are all stimulatory antibodies produced against these guys. So they have excessive production of T3, T4. They have excessive production of T3, T4 for the patient. So that will cause Graves' disease. So please don't forget the physiology and the problems in thyroid hormone production and other things. So this is high yield for your exams. So please don't forget the physiological aspects. Okay. So now we are going to see about the various values in thyroid profile. So thyroid profile is based purely on the physiology. So in thyroid profile, the commonly done investigations are free T3, free T4 and TSH. These are the three commonly done values in thyroid profile I want you to remember. Free T3, free T4, TSH. So what is the value? Usually in exams they may ask these values because it is there in Bayesian law. So free T3 is, I used to remember like 3 to 9. It is remembered as 3 to 9 micromoles per liter. So micromoles per liter, though it is not the accurate value in Bailey, remember like this, 8 to 24 nanomoles per liter. So why I am telling this? Because 3 in the multiples of 3 it is T3 3 to 9. In the multiples of 4 it is 8 to 24 nanomoles per liter. And TSH is usually less than 3 milliunits per liter. So please don't forget, TSH is less than 3 milliunits per liter. So these three values you routinely do in all patients. In all thyroid patients we will do free T3, free T4, TSH. So now let me tell you, if it is a hypothyroid, what are the findings you get in these patients? Hypothyroidism, what are the findings you get means free T3, free T4 and TSH. What will be the values? Free T3 may be normal or decreased. Free T4 may be normal or decreased, but TSH will be increased. In all cases, TSH is increased. If it is hypothyroidism, TSH is definitely increased. Similarly for hyperthyroidism, see what happens. Similarly in hyperthyroidism also, if you see free T3, free T4 and TSH is measured, TSH should be decreased and free T3, free T4 may be normal or increased. So free T3, free T4 may be normal or increased, but TSH is decreased. So what is the most sensitive investigation? Most sensitive investigation to diagnose hypo and hyper is by means of measuring TSH values. TSH value is the most sensitive investigation. Please don't forget this. Please don't forget TSH is the most sensitive value. Now I'm going to tell you a few MCQs based on thyroid profile, certain MCQs. You want to remember certain MCQs from thyroid profile. The first MCQ is, I want to diagnose subclinical or early cases of hypo or hyper. I want to diagnose subclinical or early cases of hypo or hyper. What I will do is, I will measure free T3, that is used to measure early and subclinical cases. So this is one MCQ. So early and subclinical cases is used to measure free T3. Free T3 is by means of measuring this. Early cases and subclinical cases are diagnosed by measuring free T3. And I want you to know what is this syndrome known as Refitoff syndrome from Schwartz. So Refitoff syndrome, what is Refitoff syndrome? I told you, whenever there is T3 or T4 increased, automatically what will happen to TSH? It should decrease. So Refitoff syndrome is a syndrome in which, in spite of increase in T4, TSH is normal, or even it may be sometime increased. This is known as peripheral T4 resistance syndrome. Peripheral T4 resistance syndrome known as Refitoff syndrome. One expected MCQ for your PG exams. So what do you mean by Refitoff syndrome? Please don't forget, Refitoff syndrome is a condition in which there is peripheral T4 resistance. In spite of increased T4, the TSH is not coming down, it is normal or increased. This is known as Refitoff syndrome. So these are some MCQs I want to remember from thyroid profile. So thyroid profile, please remember 3 to 9 micromoles is T3, 8 to 24 nanomoles is T4, TSH is less than 3 milliunits per liter. So these are the values you do in routine thyroid profile cases. Okay, so now what other investigation you do? When a patient with thyroid problem comes to you, what are the investigations you do? Or other investigations apart from thyroid profile, the investigations will be done, or ultrasound of the neck will be done. Please don't forget, ultrasound of the neck is done. Ultrasound of the neck, which is showing you the thyroid gland is done. It helps to locate, to identify it is a swelling arising from thyroid gland, to know the consistency of the gland, whether it is solid or cystic, you can identify, and you can also look for any nodes, all those things. Ultrasound neck is done first. Before going for FNAC or any other investigation, you should go for ultrasound neck. Ultrasound neck is now having a grading system known as TIRADS, same like BIRADS, Thyroid Imaging Reporting and Data System. Please don't forget, it is known as TIRADS, Thyroid Imaging Reporting and Data System, based on the following factors: composition of the tumor, composition of the gland and tumor, echogenicity, size and echogenic foci. All these are taken into account. Composition, echogenicity, size and echogenic foci are taken into account, and we have TIRADS grading, same like BIRADS, from 1 to 5 we have grading system. So far this question has not come in the exam, so don't worry, just remember TIRADS is also available for thyroid, similar to BIRADS, similar to PIRADS, prostate. Thyroid, BIRADS is breast. So this is thyroid imaging reporting and data system. Please don't forget this point. I want you to remember this point for your exams. So please don't forget this point. And now coming to pathological examination of choices, FNAC, fine needle aspiration cytology. So nowadays many pathologists are doing, instead of FNAC, FNNAC, fine needle, non-aspiration cytology, fine needle, non-aspiration cytology is done nowadays. So we have to put the needle and we have to do multiple prick and take the tissue will be collected in the needle hub. In FNNAC, we don't do aspiration. So we just, with the needle and the syringe, without negative pressure, we just put the port in multiple places in the tumor, take the needle out now, take the syringe out, take some gas in the syringe and push the needle now. So now the needle hub is having the tissue. The tissue will now get laid out on the slide. This is known as FNNAC, and with this FNAC or FNNAC, we have a classification known as Bethesda classification of thyroid swellings. Bethesda classification of thyroid swellings, in which the types are Thy1, Thy1C, Thy2, Thy3, Thy4, Thy5. These are the 5 types of Bethesda classification. Thy1 is non-diagnostic. Please remember, it is non-diagnostic. Thy1 is non-diagnostic. Thy1C is cystic lesion. It is a cystic lesion in thyroid gland. If there is a cystic lesion in thyroid gland, if you aspirate, there are two things can happen. Number one, the cyst can completely disappear. It can completely disappear. Okay, if you aspirate, the thyroid cyst can completely disappear or it can incompletely disappear. So if it is incompletely disappearing and there is some solid component, no doubt we have to do surgery. Incompletely disappearing, some solid components are present, we have to do surgery. If it is completely disappearing, but it is again and again recurring for more than 3 times, recurrence happens. More than 3 times recurrence happens, then also we have to do surgery. So solid component is present, after 3 times there is recurrence, then you have to do surgery in a thyroid cystic lesion. So please remember, that is known as Thy1C, Thy1C. Thy2 is a benign lesion. I hope this will be asked as an exam question. Thy3 is follicular neoplasm. Please don't forget, Thy3 is follicular neoplasm. Thy4 is probably malignant, suspicious of malignancy. Suspicious of malignancy is Thy4. Thy5 is definite malignancy. So please don't forget, this is Bethesda classification. So Bethesda classification helps us to decide the management. Thy1 is non-diagnostic, Thy1C is cystic, Thy2 benign, Thy3 follicular, Thy4 suspicious of malignancy, Thy5 is definite malignancy. So please don't forget Bethesda classification of thyroid pathological examination. What is thyroid pathological examination? And in thyroid patients, before operating thyroidectomy, one important investigation is must, that is known as ideal scopy. Can you tell me why we should do ideal scopy? In thyroid patients, before operating for thyroid, we must do ideal scopy. Indirect laryngoscopy, because 3% of patients may have occult vocal cord paralysis will be present in 3% of the patients. We have to document that 3% of the patients will have vocal cord paralysis. We have to document that before going for surgery for medico-legal purpose. So for medico-legal purpose, we must do this ideal scopy. Please don't forget, we should do ideal scopy for medico-legal purpose. In most of the patients, 3% patients will have occult paralysis. Okay. So what are the investigations I have discussed? I have discussed thyroid profile. I have discussed about ultrasound of the neck. I have discussed about pathological examination. And now comes the most important high-yield topic for your exams: radioactive iodine. Radioactive iodine uptake study. Very, very important topic for your exams from thyroid. Radioactive iodine uptake study. Please remember, I hope you remember the physiology. So in the physiology, I told you, when you give iodine through fish, immediately the iodine will be trapped by the thyroid gland. Same concept is given now. Instead of fish, let me give radioactive iodine substance mixed in milk, like iodine 131, iodine 123, iodine 132 are given by oral route, by mixed with milk, iodine 131, 23, 32. Or else I can give IV, technetium 99M can be given. Technetium 99M can be given, which has an half-life of only 6 hours. Whereas iodine 131 has half-life of 8 days. 123 has 12 to 14 hours. 12 to 14 hours. Please remember, though I am telling very fast, you should not forget these values. Iodine 131 is 8 days, iodine 123 is 12 to 14 hours, technetium 99M is 6 hours, and for iodine 132 it is 2.5 hours only. So therefore, in this, what are all used in practice means, in practice we use only iodine 131 and 123. So now let us assume I am giving iodine 131 to the patient. The moment I give iodine 131, the gland will trap the radioactive iodine like this. Immediately the thyroid gland will trap the radioactive iodine, and it will emit beta radiation. Immediately by taking the radioactive iodine, it will emit beta radiation. So the radiation emitted by that radioactive iodine is beta radiation will be emitted. And this concept of emission of beta radiation is used for both diagnostic purposes as well as for therapeutic purposes. We use this substance. So diagnostic and therapeutic purpose, we use radioactive iodine substance. So please remember, instead of normal iodine, I am going to give iodine 131, iodine 123 or technetium 99M scan. Some of these substances will be given. And then I will, based on the beta radiation exposed, we use a special gamma camera. We have a gamma camera to scan the thyroid gland about the uptake and all. We can now develop, we can see with the help of gamma camera on the thyroid gland. That scan is known as thyroid scan. With radioactive iodine uptake, we will do a scan known as thyroid scan, and we will do many diagnosis and therapeutic things. So now let me tell you what are all the diagnostic uses, high yield for your exam. Diagnostic uses of radioactive iodine are: number 1. I told you, if you give 100 units of radioactive iodine, if less than 16% is uptaken, it is known as hypothyroidism. Less than 16% is uptaken, it is hypothyroidism. If it is more than 48% uptake, it is hyperthyroidism. 16 to 48% is normal uptake. So we can diagnose whether the case is hypo or hyper by using this. Number 1 use. Number 2, if there is a nodule in the thyroid gland, we can see whether it is warm nodule. This is a warm nodule or this is a cold nodule like this. Cold nodule is a nodule which has less activity than the surrounding tissues, than the surrounding thyroid tissue like this. So this is cold nodule. To find out whether it is a warm nodule or a cold nodule, this is cold nodule. So please remember, now New Bailey says only 2 nodules, warm and cold. There is no other nodules like hot nodules mentioned now. So warm nodule has increased activity than the surrounding tissue. Cold nodule has decreased activity than the surrounding tissue. And warm nodule is only 5% time malignant. Only 5% time malignant. Cold nodule is 20% time malignant. Otherwise, 80% of the time it is also benign. So cold nodule, 80% of the time it is a benign nodule, 20% time malignant. So this is the second diagnostic use. I am telling you the diagnostic uses, please don't forget. And to locate the ectopic thyroid, please remember, to locate ectopic thyroid, I want to find out where is the ectopic thyroid. To locate such types of ectopic thyroid, I will use this radioactive iodine uptake study. To locate radioactive ectopic thyroid, I will use this radioactive iodine. 3. 4. In case of thyroglossal cyst, please understand, this is a very interesting concept. In case of thyroglossal cyst, investigation of choice in adult cyst what? Adult cyst, ultrasound neck. We will do ultrasound neck and we will confirm that is a thyroid gland cyst and we operate it, remove it. But in children we have to do one more investigation, that is radioactive iodine uptake study. Why? In children, radioactive iodine uptake study should be done because in children I want to know whether there is normal functioning thyroid gland is present. If there is no normal functioning thyroid gland and if this is the only functioning thyroid gland, the thyroid gland cyst is the only functioning tissue. So I want to rule out functioning thyroid gland. If there is no functioning thyroid gland and thyroid gland cyst is the only functioning thyroid tissue, I won't operate it in children because the babies will end up in cretinism. But in adults, this concept is not there. In adults, you can operate. Even if it is going to be the only operative tissue, only functioning tissue, don't worry, we can operate. But in children, to rule out functioning thyroid tissue, I want to rule out the functioning thyroid tissue. That is very important. Fourth point. Though I am discussing the 5 points, the fifth point is the only place we practically commonly use. What is it? After total thyroidectomy for malignancies, after total thyroidectomy for malignancies, I will look for metastasis by using radioactive iodine uptake study. Now you can ask, sir, why should you do after total thyroidectomy? Why don't you do before itself? The answer is very clear. If I don't remove the gland and give radioactive iodine, the entire radioactive iodine will be taken only by the thyroid tissue. Therefore, I should do only after total thyroidectomy, not even after chemotherapy. It is only after total thyroidectomy. I will do this test to look for METs. Please remember, this is a classical MCQ. So what is that? Important point is after total thyroidectomy for malignancies, I want to look for METs. So what are the uses? To look for hypo or hyper, to look for warm nodule or cold nodule, to look for ectopic thyroids, to look for functioning thyroid gland in a thyroglossal cyst in children, and to look for METs. Very important use to look for METs. So these are the diagnostic uses, and for diagnostic uses we mostly use iodine 123 is mostly used. Iodine 123 is mostly used for diagnostic purposes. Coming to therapeutic purposes. Therapeutic purpose we give high dose. High dose. For example, for diagnostic we give very low dose, but for therapeutic purpose we will give 100 to 200 millicuries. We will give 100 to 200 millicuries, and we use radioactive iodine 131 is usually used. And the two important therapeutic uses are, it is the drug of choice or treatment of choice for Graves' disease. For Graves' disease, this is the treatment of choice. Please don't forget. For Graves' disease, this is the treatment of choice. Okay, please don't forget this. And to destroy the METs, this is the treatment of choice. To destroy thyroid cancer METs. So to destroy thyroid cancer METs and to treat Graves' disease, we use this. It is used to treat Graves' disease and to destroy thyroid cancer METs. These are the only two therapeutic uses. So the two therapeutic uses, and in therapeutic purpose, we use radioactive iodine 131. Okay, we use radioactive iodine 131. So this radioactive iodine has a list of side effects like immediate side effects. So the immediate side effects include the pain in the neck pain. They may develop thyroiditis because of radiotherapy being given. They will develop thyroiditis, and the salivary gland can be affected, resulting in sialadenitis. The thyroid gland will go for thyroiditis, neck pain, sialadenitis, and sometimes there will be cerebral edema because please remember, whatever the structures nearby, they all get problem. Like vocal cord can go for paralysis and bone marrow suppression. So though these are all immediate side effects, they will recover, like neck pain, thyroiditis, sialadenitis, cerebral edema, vocal cord paralysis, bone marrow suppression. All these are immediate side effects. Usually they recover. What are the long-term tumors you get? Long-term tumors. So please don't forget, this is an expected MCQ topic. What are the tumors you get in long term? This question can come for your exams. I want you to remember leukemia. First point, leukemia. They may develop leukemia. Second point, please remember, they may develop papillary cancer of thyroid. I want you to remember this topic, this red lettered words: papillary cancer, thyroid, anaplastic cancer of thyroid. Anaplastic cancer of thyroid. You can develop breast cancer, gastric cancer, gastric cancer. So breast cancer can develop, gastric cancer can develop, lung cancer can develop, and salivary tumors can develop, salivary tumors. And as usual, radiation exposure can cause bladder cancer also. Bladder cancer also can happen. So these are the various tumors. That is why we are very much worried. So they can cause long-term many cancers like leukemia, papillary cancer, anaplastic cancer, breast cancer, gastric cancer, lung cancer, salivary, bladder cancer. And what are the long-term damages? Long-term damage. So long-term, what are all the permanent damage? Long-term, permanent damage because of this therapy. Long-term, they will go for permanent infertility. Infertility can happen. They can go for abortions. They can go for pulmonary fibrosis. So please don't forget, they can go for pulmonary fibrosis. Bone marrow suppression. Ovarian and testicular failure. What are all the problems in long term, or these problems can happen in long term? And apart from that, they can go for hypoparathyroidism. Please remember what are all the side effects. So on giving radioactive iodine, immediately you can get sialadenitis, thyroiditis, all those things. In long term, you can get some tumors, and in long term, you will get more issues like damage of ovary and testis, resulting in infertility and abortion. Lung can go for fibrosis, parathyroid can go for hypoparathyroidism. So what else you should do then such cases of patients who are given radioactive iodine 131? What you should do them? You should give this radioactive iodine, and during therapy time, 8 days isolate them, keep them separated, isolate them, or quarantine them for 8 days. Don't spit in the public. Don't pass urine in the public. Don't kiss anyone. All these instructions are advised them. Otherwise, what will happen? They are having radioactive iodine 131 here. As you go and kiss them, the radioactive iodine 131 will come and attack your thyroid gland, and you will go for hypothyroidism. Please remember this. So don't spit, don't pass urine, don't kiss them. Isolate them for 8 days. This is a very important point in radioactive iodine uptake study. And to conclude radioactive iodine uptake study, I want to tell you, radioactive iodine uptake will be used to find out the various causes of hyperthyroidism. It is used to find out the various causes of hyperthyroidism or toxicosis. It is used to find out various causes of toxicosis. So if there is a patient with hyperthyroidism and toxicosis, if there is excessive production of gland, excessive thyroxine production, if there is excessive T3, T4 production, they will have what? If there is excessive T3, T4 production, they will have increased radioactive iodine uptake. Please remember this. But if there is no excessive T3, T4 production, but there is only increased release of T3, T4, release only, not production. Whatever there is in the gland, increased release only. only release, but no production. Such cases will have, please remember, interesting point, will have decreased or normal radioactive iodine uptake. So now with this, we can differentiate hyperthyroidism. A patient coming to you with a toxicosis, we can say whether it is increased radioactive uptake and decreased radioactive uptake, and we can list out the causes. For example, this is asked in exam. So where are the places who have toxicosis but have decreased radioactive iodine uptake? Answer is number 1, thyroiditis patients. Thyroiditis patients in acute inflammatory phase, there will be increased release of hormones. Increased release of hormones in acute inflammatory phase. So therefore, thyroiditis will have decreased radioactive iodine uptake. Number 2, thyrotoxicosis factitia. Thyrotoxicosis factitia. What is this? Thyrotoxicosis factitia means excessive consumption of thyroxine causing thyrotoxicosis factitia. So excessive thyroxine tablet being taken. That is another place where radioactive iodine uptake will be less. And another is hamburger toxicosis. What is this? Hamburger toxicosis. Hamburger toxicosis is a condition in which the guys from South America, they eat the thyroid gland of the buffalo in the burger. So that is why it is known as hamburger. In the burger, they keep thyroid gland of cow or buffalo and eat. That will also cause toxicosis. So these 3 points please don't forget, because all other things will come here. All other things will come this side. So what are the things that will come on decreased radioactive iodine uptake, or all thyroiditis, thyrotoxicosis factitia, hamburger toxicosis. In all these cases, there is no increased production. There is only increased release. Where are the increased production? Like increased radioactive iodine uptake is seen in Graves' disease. Secondary toxicosis. So whatever you remaining, we'll put here. You put here. George Basidos. George Basido toxicosis is due to excess iodide consumption. Excess iodide consumption causes George Basido toxicosis. Struma ovary can cause toxicosis. Hydatiform mole. Hydatiform mole. So what else? So hydatiform mole, Graves' disease, secondary toxicosis, struma ovary, hydatiform mole, all these guys will cause excessive radioactive iodine uptake. Okay, please don't forget TSH secreting pituitary adenoma also. In all these cases, T3, T4 is produced in excess amount. So it is produced in excess amount, including some drugs like amiodarone. Some drugs which can cause increased production is amiodarone. So these are the causes of hyperthyroidism due to radioactive iodine uptake increase, and these are the 3 causes of decreased radioactive iodine uptake. Okay, just let me show you the PowerPoint now. So this is a very important topic. Please don't forget the introduction of thyroid. The introduction of thyroid thing. I want you to remember this is the ACR Thyroid grading from Sabistan. It is based on composition, echogenicity, shape, and a margin and echogenic foci. This question is once asked in Chipmer, only one time. So far in the past 10 years, only one time asked in Chipmer. So it is based on, I used to remember with the mnemonic SESME. So ACR Thyroid grading, American College of Radiology, ACR Thyroid grading is this. And I want you to show the anatomy here. Please remember the recurrent laryngeal nerve, how is it cooking and coming back. And I want you to remember this Beer's triangle. Please don't forget Beer's triangle. It is the place where the nerve is at highest risk of injury. It is very close to the Berry's ligament attachment. Okay, see this point. So this is Beer's triangle. You can see this is common carotid artery, inferior thyroid artery, and this is tracheo-esophageal groove. This is Beer's triangle into which the recurrent laryngeal nerve is at high risk. At this point, you should know what is Berry's ligament. So Berry's ligament is a ligament which is seen posterior-medially. This is the thyroid gland. Posterior-medially, there is a thick attachment of pretracheal fascia with the thyroid gland and trachea. That attaches the thyroid gland with the trachea, known as Berry's ligament. This is a very important reason for movement of the gland with the protrusion of tongue. Sorry, with the movement of the gland with the deglutition. So very important reason for deglutition, the gland moves. Thyroid gland moves with deglutition because of Berry's ligament. And there is a neat PG 2020 question you would have seen. Why the thyroid gland when it enlarges, it's an anatomy question. When it enlarges, it is not going up, only it is going retrosternal. Why it is not going up? It is because of the reason the pretracheal fascia. It extends from arch of aorta here and it attaches at hyoid bone. This is pretracheal fascia. From arch of aorta to hyoid bone. Therefore, the swelling, if it enlarges, it comes only up to hyoid bone there, and below it can extend up to the superior mediastinum. So pretracheal fascia is the fellow who prevents it extending upwards. Okay. So tubercle of supracanthal is the most prominent posterolateral portion where the point will be point towards recurrent laryngeal nerve. The tip will be pointing towards recurrent laryngeal nerve. Please don't forget. So this is a Cernia classification I told you. Type 1 means the external laryngeal nerve is running more than 1 cm above. 2A, 2B means less than 1 cm, and in 2A it is running above the gland, and 2B it is running on the gland. Cernia classification. Please don't forget. So please don't forget the nerve functions, and don't forget half-life of T3 is 1 day, T4 is 7 days. 1 day for T3, T4 7 days. And don't forget the values. T4 is 8 to 24 nanomoles per liter, T3 is 3 to 9 micromoles per liter, TSH is less than 3 milliunits per liter. So remember these 3 values. I told you the investigations, Bethesda classification. Please don't forget Bethesda. Thy3 is follicular neoplasm. So what is Thy3 means? It is follicular neoplasm. We don't know whether it is benign or malignant. It is not known. We have to find out. It may be benign or malignant. Thy3. So please don't forget Thyroid grading. And this is radioactive iodine. You can see this is cold nodule and this is warm nodule. Warm nodule is 5% malignant. Cold nodule is 20% malignant. So you can see the cold nodule here, a hot nodule here. This is a Graves' disease. There is a diffuse uptake. And this is autonomous solitary nodule, multinodular goiter, both hot and cold nodules seen. In thyroiditis, the radioactive uptake is decreased. So you can see the meds. A patient having meds, you are diagnosing with radioactive iodine uptake. Okay, this is what I told you. Where are the places where there is decreased radioactive iodine uptake? Increased release of preformed hormones. If there is increased release of preformed hormones, there will be decreased radioactive iodine uptake. Please don't forget, it is in thyroiditis, thyrotoxicosis factitia, and in hamburger toxicosis. And in hamburger toxicosis, you will have this point. This 3 point you should not forget. Other things you can remember. So where are the places there is decreased radioactive iodine uptake will be asked in exam. And please don't forget, after radioactive iodine ablation, the Graves' disease patient becomes euthyroid in 2 months. Very interesting MCQ from Bailey Law. After radioactive iodine ablation, the Graves' disease patient becomes euthyroid in 2 months. But at 6 months, what happens? When you go and examine them back at 6 months, 50% of them will be euthyroid, and remaining 50% will be either hypo or hyper. This is an interesting point. You remember this. So 50% of them will be euthyroid, and 50% of them will be hypo or hyperthyroid. Okay, so at 6 months, but 2 months, most patients become euthyroid. At 2 months, most of them become euthyroid, but after 6 months, it will not be the same. Only 50% will be euthyroid, remaining 50% will be hypo or hyper. So can you tell me what are the contraindications of radioactive iodine therapy? So where all you should not use this radioactive iodine therapy? In children, in pregnancy, in patients who have nodule in the thyroid, nodules present in the thyroid, and for patients who are having thyroid ophthalmopathy, and smoking females. So these are the places where radioactive iodine therapy should not be used. So what are the places of contraindication of radioactive iodine therapy? Is children, pregnancy, presence of nodules, thyroid, toxic ophthalmopathy, and smoking females. In all these patients, we should not give radioactive iodine therapy. Please remember, this is also a very basic MCQ for your exams. So this completes the introduction of this chapter. I hope you understood the introduction of thyroid. So thyroid and breast are two important chapters. I want you to know everything about thyroid, everything you should know about thyroid, and this is the basic of thyroid. Please don't forget this. Now let us go for benign lesions.